So I'd just like to take a quick minute, first of all, and introduce my colleagues. So as I said, my name is Lorraine, and I'm going to hand it over for the support. We're 3 countries right here, right now, and we also have support from our regional office, Asara from the Nairobi country office. And I'm going to hand it over to Nasir to introduce himself, and we'll just go down in this order. And then in the end, I would kindly request if we can have an introduction from the country office teams, and if we have any participants present, colleagues from the Ministry of Health. Over to you, Nasir.
Thank you, Lauren. Good morning, good afternoon, colleagues. Hi. Can I go ahead?
Yes.
Yeah. Welcome, colleagues, to this training. As Lauren has already specified that the focus of this training, which will happen today, tomorrow, and day after tomorrow, is mainly on the outbreak response, and we will be aspects of it, and most of it remain around C4D, and that's going to be really very helpful for all of us. And as we start the year, and then there are already planned, the outbreak response campaigns, and quite a few countries, I think most of them who have been attending these trainings, their surge budget has already been approved, and they are, we know, very much, accelerating their process of putting the things together, their HR and all the planning according to the time frame which they have. So I really feel very happy to be part of it, and particularly we welcome colleagues from Uganda office, my colleagues from UNICEF office, WHO colleagues, their consultants, their partners, and particularly government officials, and also the colleagues and counterparts from Sierra Leone. So I give back the floor to my colleague Lauren to take the agenda further. Thank you.
Thank you, Nasir. Tommy?
Yeah, good morning, good afternoon, everyone. My name is Tommy Laulayainen, and I'm a C4D specialist in UNICEF New York Polio C4D team. And I mostly work with the 2 endemics, Afghanistan, Pakistan, but I'm also part of the NOPV2 preparedness verification team, which is looking at the country's preparedness for the NOPV2 introduction. And particularly when it comes to C4D, there are certain requirements that the country has to meet before the vaccine is issued. So I'll be working with the countries in the outbreak countries as well as in the endemics. Thank you.
Thank you. Aaron?
Yes. Oh, sorry, I've already introduced myself. My name is Erin Vogue. I'm the consultant for knowledge management with the Polio C4D team in New York. And I'll be helping to facilitate in the back end for the training, making sure everything runs smoothly. So if you have any issues, feel free to reach out to me or send me a chat.
Thank you, Aaron. Kashan?
Hi team, my name is Hamid Kashan. I am with the UNICEF Polio team in New York, and I work specifically on misinformation management, and I'm really excited and looking forward to working with you guys over the next 3 days.
Thank you, Kashan. Mariana?
Hi everyone, welcome. My name is Mariana. I work as a C4D lead and outbreak team in New York, in Geneva headquarters. I'm also a co-chair of an OPV communication working group, as well as the readiness verification group. Thank you all for joining. Quick, just to note that you're very welcome to reach out to myself and Nasir and the team on the call for any support beyond this training. And I think we will be referring to what support you can get, but anything outbreak related, you're very welcome to reach out with questions anytime. And me and the team are on standby to support both of the countries jointly with Nasir. Thank you and welcome.
Thank you. And before I go over to the country office teams, last but not least, and my apologies, Farhad, if you're online, if you can please introduce yourself.
Yes, thank you, Lauren. Hi, my name is Farhad Imam Bakiev. I'm a C4D consultant with the Polio team in Geneva, Rapid Response Team. Thank you.
Thank you. I do have a couple of other colleagues who will be providing us support. I see Lawson is on the call. They will be part of the team that support us for the NOPV2 trainings. Lawson, would you?
Hi, good afternoon. Greetings from Nairobi. Happy New Year. My name is Lawson. I work with Tesaru as a vaccine management and logistics specialist. It's my pleasure being here. Thank you.
Thank you. And I'm going to hand it over for introductions from the Uganda country office. I think Miriam might be on the call, and then we will go to Sierra Leone.
Hi, everyone. Yeah, this is Miriam in Kampala, and I have colleagues from UNICEF on the line. Did you want them to introduce themselves, or you want me to say who they are?
If you just say who they are, and then,
okay.
Yes, and if we have anyone present here from the MOH.
Okay, from the C4D team, we have Abel, we have Douglas, we have Enoch, and we have Rita. From the zonal office, we have Martin. Then we have our EPI colleagues, Patrick and Roy Pakutho. Rita is also representing the health promotion team at Ministry of Health. She's our C4D consultant who supports Ministry of Health. We have my colleague Benjamin Sensas from WHO, who's also the C4D person there. I see Fred Ingania from Ministry of Health. I think I saw him just log on just for a second. Yes, there he is. And he works in the UNEPI, the EPI division at Ministry of Health. I think that covers everybody from the UNICEF team. Thank you.
Thank you. And do we have anybody from the Ministry of Health? I think you said Fred was there. If you'd like to introduce yourself. And then I will move on to Sierra Leone.
Thank you very much. Am I clear?
Yes, you are.
Okay, thank you very much. I'm Fred. Just like Miriam indicated, I'm Fred Nganya. I work with the Ministry of Health as a monitoring and evaluation officer. Thank you.
Welcome, thank you. And if I can move over to Sierra Leone, I believe we have colleagues on the line.
Hi, Lauren. Hi, everybody. So I'm Cindy from C4D from UNICEF Sierra Leone office. I have my also colleague Samuel, C4D, with us, and I saw online Isa from the external communication team. In the room, we also have a Ministry of Health. So we have Harold Tamal, which is the Health Education Division of the ministry, also Umuawa and Leonina. And I can see online, we also have Safea and Aziza from WHO, so the communication officer and risk communication. Over.
Thank you, Cindy. And if we can hand it over to the Ministry of Health in Sierra Leone, please.
They are right here.
Yes.
Yes. Hello, everyone. As Cindy introduced, we have a couple of colleagues here. Myself, Harold Thomas, Health Education Manager and Risk Communication Lead. We also have Kotsoki, Kamara, who is also a colleague, a senior health education officer at the Health Education Health Promotion Division. We also have Umu Awa, yes, from decision with the focal person for communication. We also have Patrick Lansana here from the Public Health National Emergency Operations Center. That's the Health Security Directorate here also. And then we have another colleague, Edward Meziga, who is also in his communication here at the EOC. Okay.
Thank you.
Thank you. So welcome, everybody. So I'm going to now proceed, and we'll go through this slight introductory presentation over here. And then we'll take a look at the agenda of what we will be doing for the next couple of days, okay? I did acknowledge that we did get an email that came in for Sierra Leone, and later today we will discuss how to be able to accommodate you for the third day of the training. Okay. All right, so just to acknowledge that we are doing Zoom sessions. We're all aware why we're doing these Zoom sessions. This is actually, I think, our third or fourth training that we are trying to do it via Zoom. So please bear with us as much as possible. Just to let you know how we will run the sessions, we will have short presentations in this outbreak response training. There might be presentations, there might not be presentations. We will have discussions, and we will have small polls. We have put aside time for question and answers as this training goes on for 3 days. This is a training that we usually do in person. Apologies if it is not as participatory as it could be if we were on the ground. And so we will try and accommodate as many questions as possible in those sessions. And if not, we will take other questions that come back, park them, and then address them the following morning. Okay. Just to quickly, briefly talk, I'm going to just do a little bit of operational parts over here to let you know how we are structured. As I mentioned at the beginning, this is an outbreak response and preparedness training. We will be coming back next week to do the introduction of NOPV2 training. So I will start off, first of all, by talking about who we are. It's the partnership of the GPEI, the Global Polio Eradication Initiative, and these are the agencies that are involved. We give support to country programs. We, of course, make sure that we support governments first to take the lead. And the partners that sit with us are the Rotary, and communication, our fundraising. And actually the Rotary was the organization that came together in 1988 and requested that the partnership comes together for the eradication of polio. We as UNICEF, our main role, of course, is the procurement of vaccines, and focused heavily on the communication and social mobilization part of the partnership. We work very closely with the CDC, who does a lot of our laboratory work and gives us technical expertise. For those of you out there who have been STOP consultants in the past, you also know that this is something that is initiative of the CDC that we help to partner with and do the trainings. And we work closely with WHO, who does all of our strategic planning and the big component of surveillance. The Bill and Melinda Gates Foundation, who are our funding partners and give us our technical expertise. And because we sit as the GPEI, but we also work with immunization. Recently, Gavi joined us and came on board, which is the part of the program that looks more at the IPV component of the polio program. Okay, just to show you really quickly how we're structured, we have a team here at headquarters. Our headquarters consists of 3 offices now. So it's New York, Amman, and then the Geneva team. And an Amman office focuses more on the endemic, Pakistan and Afghanistan. And then the Geneva team, where Mariana, Farhad, and colleagues sit, focus on the outbreaks and also on high-risk priority countries. Okay. And as Tommy mentioned, so a lot of we give support into both these directions that pull us according to what their needs are. So the overall objective of this training is to prepare our colleagues. We will look at 2 things, as we mentioned. Let's look at outbreak preparedness and response. And then next week, we will start to roll out our first NOPV2 trainings. This is just one of the maps to show you. If you look over on the Asian side, you can see where the 2 endemic countries still are, which also are having a lot of outbreaks. And this is just a map to show you continent-wise where we have outbreaks, and of course, not to forget the parts of Asia that we were also giving support to, such as the Philippines recently. Okay, so where are we going? I think it's important to have this slide up just so that I can remind colleagues that, as we said earlier, this is a C4D, it's a comms training. We work as behavioral scientists, and a lot of what we do is I like to look at it kind of like everything that we're doing is kind of, if you look at your micro plans. So when we look at your trainings, how do we structure your trainings so that we are incorporating everything that you would look through the lens of a micro plan, or you could look at it from the lens of a communication strategy. So really quickly at the end of the year, I'll give you an idea of what the agenda will look like for the next 3 days. But some of the things that we will be discussing is training in the context of COVID-19, which is our new norm, and we have to be able to discuss this and make sure we're all on board with it. We will look at polio basics for outbreaks that my colleague Nasir will give us support with. We will look at crisis communication data, because we do our trainings, we do all our work to make sure that we are taking the evidence that's available for us to help us make decisions what we're doing. And as behavioral scientists, we will look at our behavioral analysis, our target audiences, as I said, microplanning, which will be done by Farhad, community engagement in IPC, and then, of course, we will also address misinformation and rumors, which will be presented by my colleague Kashan. This is an example of behavioral strategy. So just to show you that when we do our trainings, we try and align everything along with what we do in country and what is based on our structure. So this is an example of the strategy that came out of Liberia, who we just did a training with last week. And you can see, just as I showed you from the previous slide over here, and when you look at your own strategies in country, that we will cover these issues to make sure that we are prepared for this. So we will look at data, we will look at our behavioral analysis, what the objectives are to help us guide us do this work, what the tactics are, our channels of how we communicate and when we will use them, and then of course address the most critical thing. This is an example. So what I'm doing is just showing you multiple examples. We've taken the part of the training. We have looked at the analysis of the strategy that you develop in country. And just to show you, this is a sample of some of the outbreak preparedness tools that we create for you, that we've developed. And if you look at this circular diagram on the right-hand side, you will see that it's also following the same structure. It's looking at the data, the community, the micro-planning, how we engage, and of course, something that's critical for all of us, how do we facilitate and roll out these trainings so that we can reach our target audiences. Aaron, I think that's the last slide. So if it's okay from your side, I would request if you could slightly just project the agenda so that we can show our colleagues what we will be doing for the next 3 days. Thank you. Just to have set up a Dropbox folder for you. It will contain all the presentations, the agenda, all tools that we will use or we will speak about will all be in your Dropbox folder that you can download and use for your own trainings or for your own information. And as Mariana said, please also feel free to reach out to us if you need any additional information. I'm not sure if our colleague Joseph is on the call over here with us today, but one of the things that Joseph did request from the Uganda country program was additional information. He was in the training last week to do with NOPV2. We do have a folder for that, and I will be sharing that folder closer to the end of the week when we make sure that all documents are in there. But just to walk us through really quickly what we will be doing on day one, these are 3-hour sessions. So we're going to, as you can see, talk briefly about working with our campaigns in the context of COVID. We will look at polio basics, outbreak response, and then I'll hand it over to Tommy, who will talk to you about crisis communication. Aaron, if we can scroll down a little further. You'll see tomorrow that we'll get a little more, please. into some of the nitty-gritty stuff where we will discuss a little bit more about looking at data through our situation analysis. We'll come back and address looking at the audience analysis, our behavioral work, misinformation, and rumor tracking. We'll close out, and then on day 3, we will come back and look at microplans and social mapping. IPC is critical, and then we will look at some of the parts of the soft skills besides IPC, where we will address things on supportive supervision, mentoring, fatigue, etc., which is a big part that we're trying to bring into trainings, more than just looking at IPC. And then, of course, the introduction of NOPV2 and what we'll be doing the following week. Thank you, Erin. So I would like to go and talk about campaigns in the context of COVID-19. But in the meantime, I will just open up to see if we have any questions from anybody. Erin, is there anything we need to address that's coming in via chat?
We're continuing to have some introductions, and then we have a quick poll that I'll put in the chat.
Yes. So actually, my apologies. Before we do that, I'm going to hand it over to Erin, who's going to take a few minutes over here to run with the poll. Over to you, Erin.
Thank you so much, Lorraine. So we're going to use Slido to have some more interaction with you during our session. So if you go to the chat box, I'm putting in there a link to our Slido, and I'll get that up right now. Okay. So in the chat box, you'll see a link. If you click the link, this is going to take you to a browser screen. And you'll see there's a Q&A where throughout the session over the next few days, you can enter your questions into this browser. And you'll also see now a poll. So the poll has 3 questions. If you are in a room and you do not have your own computer, if you're sharing a computer, I'll project on the screen now a code that you can use to complete this on your cell phone. Okay. So once again, I invite you to go to the chat box, click on the link for the poll, and bring up the poll. The poll is now open. And I'll give about 3 minutes there's 3 questions for you to enter those questions. And then once again, if you are in the room and you need to join via your cell phone, you can take a point your camera at the QCR code in the top corner, or go from your cell phone to Slido, slido.com, and enter the event code that you see on the screen, which is 7677. So we have a few responses coming in, and I'll give another minute to hear from others. So this is great. We have 8 responses so far. We have over 25 people on the call as participants, so I'll give it a few minutes to hear some more responses. And with these questions, we're looking to hear from you your expectations for the training, what you're expecting to learn, what information, what skills you might be expecting to improve, or any other expectations that you're coming to the training with. And then question 2 and 3 is asking about some of your previous levels of experience so that we know who we have with us in the training and the broad and rich backgrounds that you're bringing to today's sessions. So on the screen, if you're still completing the questions, please do take your time and complete the questions. As there are a lot of thoughts with expectations, I'll start to go through those as anyone who's remaining with the questions is still answering. So for expectations, we have knowledge, improving ability, communicating risks during outbreak and pandemics. Certainly we're facing two very big outbreaks right now and operating during a pandemic. Key component of response. New insights into risk communication and community engagement for polio and COVID-19, as well as sharing resources. Gaining deeper knowledge about polio outbreak communication planning, implementation and monitoring. Innovative knowledge communicating issues around the recent outbreak of OPVD. New community engagement strategies, activities to foster individual acceptance of polio vaccine and other vaccines. Polio outbreak response skills. Knowledge, technical details about polio outbreak response. Certainly, again, COVID-19 with polio managing misinformation, integrated microplanning. This is great to hear some of your expectations. Certainly the overlap of COVID in the COVID context. So I'll flip now. So we have 17 responses to get a sense for the backgrounds that we have. So it's really exciting, excellent to see just the rich knowledge that we have and experience in the room. 61% have more than 3 years experience in working in an outbreak response. So we really hope to look to you as we're facilitating this training, making it very interaction and hearing from you with your responses. So please bring that your knowledge and your questions as we're interacting during the next 3 days. And finally, have you ever participated in a polio campaign? 89% have. So again, we have a lot of very knowledgeable colleagues on the line, and we look forward to learning from each other. And so with that, Lorena, I'll hand it back over to you.
Thank you, Erin. So before I go on, just by looking at these polls, just a couple of reminders. As I mentioned earlier, this is a training that's usually done for 3 days on the ground. So I hope we can address as many of these issues as possible, or also let's look at it as a good review to come back when we do our trainings and what goes on. I'd like to hand it over really quickly to Tommy. To see, Tommy, is there anything you'd like to add or bring forward, please?
Obviously, the expectations to some extent might be really, really high. And as you said, Lauren, normally this training is on the ground for 3 days. Now it's 3 hours in 3 days. But we really value engagement and discussion and inputs, particularly seeing that there's an experienced outbreak polio people on the call. So I think that's the added learning approach anyways. We want to engage with you and learn from each other as much as possible. Hopefully we will be able to give you some very specific NOPV preparedness next week, which is a separate session. So we have deliberately left it out from this 3 days and do a more focused NOPV only session in the coming week. So that's how we approach this. So looking forward to the discussions and engagement.
Okay, thank you, Tommy. Mariana, anything from your side?
No, thank you, Lorraine. This is great, and I wish you and the participants good luck. And don't hesitate to, as I said, reach out and ask for more questions, or if you need any specific support on any of the topics that we will discuss. Thank you.
Thank you. Okay, I am going to try and bring up my screen here again. Colleagues, anybody, any issues, anything you'd like to bring up? Any comments?
Just a reminder that with that Slido link, you can continue. There's on the Q&A side of the browser, continue to write any questions either there or in the chat box on Zoom if that's easier as we go through the presentations. We'll organize them and make sure to bring them up during the Q&A later today.
Okay, thank you, Erin. I would just like to take about 2-3 minutes just to talk about working in the context. I know a lot of us sitting over here are health officers, clinical officers, but it's important that we just remind ourselves about this. I know we do every day, but we have to as part of this training. Also because we are part of the polio team, and one of the biggest things we do for our work is we go door to door. And as you know, at the beginning of 2020, well, in the spring of 2020, this was something that we put on hold. We had to bring all hands on deck. And so for me, always a small reminder about our work and what we do in the context of COVID-19. Okay, so as we know from our Hippocratic Oath, a big thing for us is the duty of care and to do no harm. And just a reminder that we look at it from both angles, right? One of them is to make sure that we promote these safe techniques on how to prevent the spread of COVID-19 while doing no harm to the communities by all the programs given to us. But also it's very important for us to remember that part of our work also is to protect our health workers and to make sure that we take care of them. As we do this, just a reminder that, of course, for everything that we give you, that this is controlled, and we look at our governments first, and we look at the national authorities to make sure that when we are doing our work and we begin these campaigns, that we are abiding by the guidance that's been put out over there, everything from sanitation to make sure we take care of our frontline workers, to make sure that they are able to wash their hands, that they have the right protective equipment, and of course that we do all our outreach activities as required. This was a document that was put together by partners in the GPEI, and it is to help us to do our work when we go out and we start our campaigns. It is in the Dropbox folder, but I just wanted to share it with you over the next couple of slides, just a reminder. If you go through it, and when we do trainings, and we do them on the ground and in rooms, you will see that when you go through this document, that there is information available that will show you of all the things you need to take into consideration during COVID response. For some of you, these are things that we sometimes don't think about, and especially when we're training, it's like when we do our preparation stages, it's just like being a school teacher. You have to take everything into consideration when we send the kids to school. What is the distance between each other? Where are you guys sitting? It's something Erin and all of us have been discussing over the last couple of days. How many people will they be in a room? Will they have the social distancing? And this is the same thing that happened in this document that's been created. So this is just a sample of some of the things that are in there that you will have for your use. As I was just speaking, a few things that are important for us to remember are our room setups when we do our planning for our trainings. Will we have interactive sessions? Will we have activities? How do we keep in mind that we are working during COVID-19? Taking the trainings, and how do you increase the time and the space? Something that we automatically just think that's a 3-day training, but no, things change, and how are we doing that with people on the ground? How will we screen our audiences? All different countries have their own regulations of how this is done. it's something that takes time. What resources do you have available for those trainings? And what are we learning? And do we have to include COVID, and not only COVID, but things that also go beyond polio when we go out there, especially for us when we do our campaigns and we have the opportunity to go door to door. Are we just coming with polio? There are a lot of parents that were the first ones at the door, and what other information do we have? Okay. I like to remind colleagues, as I always remind myself, that our role is also to train. We are also coaches and we are mentors for the work we do when we go out there. We need to make sure that we do have the right IPC skills. We have to think about our health workers to make sure there is a reduction in stigmatization and what's going on in the communities. Avoid any activity that attracts crowds. This is not the time when we really want that. Consider what we do when we do our house-to-house visits. When we are at the doors, you know, our distancing and everything. And then, of course, as we said earlier, take instructions on infection control. Okay, so I'm a behavioral scientist. As I said, I work with a polio program, and one of the things I do is capacity development. And for me, when I look at capacity development and I look at my colleagues who are out there, and we know that when we do these trainings and we roll out trainings, how do we look at things and how can we look at them from multiple angles to understand better what we are trying to do? And so I made this small little infographic to remind me of what we do in our daily lives and what we would expect to see from communities, what we'd expect to see as parents. And I'm just going to take a minute and walk you through it. So I think about it when we go to restaurants, and what do we think about when we go to a restaurant? Okay, so I own a restaurant, I have my supplies, I have great chefs, I have good food, I have good service, I have my waiters. Okay, what do I want? I want demand, right? I have my supplies and I want my demand. I want people who love to eat out, they love to go to cafes, and they like good food. And my action, what I want to do is completely to promote them to continuously come to the restaurants. So I evaluate my service and I think, are they knowledgeable? Are they caring? Do they, right? The soft skills. Because if I want to keep people happy, I need to make sure that this goes on. So for all the work we do, we always think that if we have our supplies and we have our good service, then we will always have positive action. So we take these trainings and now we just move it from our daily lives into a clinic, right? I have my cold chain, I have my vaccination, I have my staff, I have my Ahmeds, I have Lawson, we have our teams, we have our Tommies. So that's all there for us. What is it? I have my service, right? I want to make sure that they have the right knowledge, the right IPC skills, the tools, right, that we send them out into the field. And we also give them incentives to do their work because we want the demand to keep coming. We want parents and caregivers to continue to vaccinate their children and to come to the clinic. So it's the same thing, right? You have your supplies and you have good service, then you're going to have positive action. And to me, this is a critical thing when we train, is to works. But now we have to look at things in the context of what's going on today, okay? We have an increase of outbreaks. We also have the introduction of a new vaccine that's coming out under an EUL, and we have to think about it and everything that we do in the context of COVID-19. So I have my healthcare worker. They're trained. I need to make sure they're knowledgeable in what they do. They have the right information. They have the right tools to do their work, that they do have the right IPC skills, that they have everything that we're talking about, the duty of care and do no harm, that they're thinking about all these perceptions when they go out and they do their work, which is part of our trainings, right? Why we look at data, are we answering those questions? Do we address the rumors that might be out there, the stigmatization, the fears? And then also community engagement to make sure that we bring back what we stand for as C4D, which is ownership. I think this is a very important slide because we have to remember that for everything that we are doing, our biggest focus is going to come down to this frontline worker to make sure that everything that we take forward when they go to the door and they meet with that caregiver, that they have the right tools, the incentives, that we are abiding by the regulations of COVID-19 in order to do our work. Okay. All right, so that's it from my side. Just a quick introduction before I hand it over to Nasser, who's going to talk briefly about polio basics, which is something that we have to do in these trainings. I will just reach out and see if there are any questions from anybody. And if not, I'm going to hand it over to Nasser and to Erin for her support. If we can proceed, please, with polio basics. Thank you.
Yeah. Thank you, Lauren and colleagues. Yeah, it's thanks, Lauren, for giving very good background, which makes my presentation easier. Colleagues, it's a short and simple presentation, but I believe it will be helpful for many things what we will be discussing in the subsequent sessions. Erin, the next slide, please. Yeah, so this is a global map, which gives a very clear picture about the polio endemic countries in which we were in 1985, when actually it is a scenario before the polio eradication was started in the full campaign mode. We can see the whole globe was endemic. Each part and every continent, the kind of effort and the struggle and time and investment has gone in this historical program, which has achieved a lot. That what we have achieved, we will see in the just next slide, please. Yeah, so again, we are at the global map here, and if you compare it, the yellow, which represents the polio endemic scenario, that the whole globe had the cases. Here we see that since 85, or when actually 88, when it started in the campaign mode, and here we are today, we can see only a small area, which is Pakistan and Afghanistan is still endemic, which means they have the wild polio virus cases still continuing there, but rest of the world has been wild polio virus free, and that's a great achievement. And then Africa continent very recently achieved this important milestone on in August, to be precise, on 25th August, Africa was certified wild polio virus free continent. So that's where we are, and we can see these green spots here. So these they represent CVDPV2 cases. So that is the circulating polio vaccine virus that we will discuss more in detail in the subsequent sessions. So that's another thing we see, and we can see that the CVDPV cases, and then in the past 12 months or so, that has been the situation, which is detailed out in the table. So what actually is polio? There will be more deeper and technical discussions on it. In a very simple layman sense, we can look at these few aspects to familiarize with us. And we know, because the just poll showed that most of you are quite experienced, but still it will be a good reminder for us. It's a disease caused by a virus that replicates in the intestine. So that's the specificities of this virus. And then it is incurable, and then it leaves a person who is infected lifelong with the lifelong paralysis. So no cure, no reversal once the infection has happened. That's why prevention is emphasized through the vaccination. And then children under 5 years most at risk. So mostly, if we look at the whole the population which is affected by it across the globe, it is the mostly I mean, 99% of this is the age group which is affected by it. That's why campaign focus is on 0 to 5 years children vaccination, and then preventable through vaccination. It can be only prevented through vaccination, and that's why vaccination campaigns are planned and implemented. So vaccination is the best way to prevent and eradicate this disease. Next slide, please, Erin. So transmission of polio virus. So there are seasonalities involved in it. It is not that the experience shows that it is not that throughout the year and the different settings and geographical and climatic conditions. It also follows certain seasonalities. There are high season for the wild polio virus or vaccine derived virus, and then low seasons, and then it is highly infectious. The infection is really very high in that one. It is not a disease of low infections. Infection is really high, and then there are certain factors which actually contribute for this infection and transmission. One of them is the poor sanitation and crowding, increased transmission. These are the factors which actually increase the transmission. Next slide, please, Erin. Yeah, this I would really request you to look at this picture. It shows the complete situation, what how polio may be transmitted, and how actually the communication and social mobilization is planned. This is from Western Uttar Pradesh in India, which was really a big challenging place at some point of time for polio eradication. So you can see that lady who is holding this paper is actually a blown up of micro plan, that is house to house visit, what Lauren was mentioning. And behind that is a person, is supervising that person, and then the person with the skull cap is the local opinion leader, and the lady in the blue top is one like my colleagues who is on the field monitoring during the campaign. And then in the background you can see polio IEC posters with a cat and other things, and then children and all the. Please, I would request you to look very carefully the whole scenario here. You can see these open channels of water there, right? And then a guy who is perched on a pipeline. I hope you all can see that one. In the background, this is actually a pipeline, a water supply pipeline, and this is one of the case in this whole region. This supply is water supply is done like that. This supply is going straight in the kitchen of these houses there, and you can see this is open channels. When I used to go in those areas, I could see the bubbles coming out of this water. That means the water supply is under these kind of channels which are open, and then highly unhygienic conditions are there. So these are one of the scenarios which make this whole social ecology of the communities more vulnerable. So in those contexts, we specifically developed a strategy. We called it underserved strategy for polio eradication, focusing on particular areas and particular population who were living in these kind of conditions. And these were the children living in these conditions who were actually host of the virus. And this is the areas which were last to eradicate polio in the whole ISARO region of WHO, and India was the last to report the last case in that area. So these conditions are the condition which you would be facing when you would be actually planning your outbreak response. Rest of the population is living in different kind of conditions which are not as vulnerable as these kind of conditions would be. So this is one of the example you can keep in mind, and what kind of focus and micro planning and the local resources you will have to use systematically. Next slide, reservoir only human. So this we know. I would just like to take opportunity to re-emphasize that the human are the only reservoir of this virus. It's a human virus. It cannot it cannot exist and remain in any other host like any animal or any bird or anywhere else. It's a human virus, and the transmission is person to person. It is from one human being to another one, and also very limited transmission is through the fecal-oral route. No other way, like other infection, like other part of the body, skin or anything. No, it is purely through focal oral focal transmission. So that is very clear in this, and we can focus when we know who are the reservoirs and how transmission happens of this virus. Next slide, please. And then we know there are three types of so that is also very clear, and we know more about it. And similarly, the types in the CVDPV also we will hear that they are of these types only. Next, Erin, please. Next slide. Yeah. So yeah, type 2 already eradicated. Type 3, and then yeah, what we are seeing now, these types which are also reported in the cases of CVDPV. Next slide, please, Erin. Yeah. So key polio milestones are such: polio cases reduced by 99.9%. So that means we are almost there, but not exactly there. It has to be eradicated 100%, not even 0.11111, nothing. It has to go to zero of any type of polio cases, whether they are wild polio or vaccine-derived viruses. So a lot has been achieved. So 2 out of the 3 types of wild polio viruses eradicated already. Only one is remaining. Africa region was certified wild polio virus free, as I mentioned earlier. Very recently, last year, on 25th of August, that milestone was celebrated all over the continent and many parts of the world. Next, please. So the vaccines are IPV and OPV. So these are 2 types of vaccine which are there. So currently, inactivated polio vaccine, which is also called IPV, that was invented by Jonas Salk in 1955 and contains killed virus 1, 2, and 3. And then oral polio vaccine, very famous, Albert Sabin, he invented it in 1961. And then trivalent OPV, 1, 2, 3, global withdrawal has happened. And then bivalent OPV, that is, which has type 1 and type 3, it has replaced TOPV in routine immunization and supplementary immunization activities, which are the normal campaigns which we have. And then we have monovalent OPV 1, 2, or type 3. So only one type would be there in this vaccine. Against type 2 outbreak. So for the type 2 outbreak, so this is the particular vaccine which is used. Next one, please. Yeah, so a training module, a training manual for supervisors is already in place. So it is introduction of NOPV for polio outbreak response to begin very recently, and my colleagues have already spoken. Lauren spoke about it, and Tony spoke about it, and there will be much more discussion. So that is a strategy with this tool is soon going to come, and there will be next week very specific training for that one. Next one, please. So these are some very important resource materials, references here. You can visit, you can look at them, and then you can find much more information on different aspects of vaccines. And then obviously more is better. That's why it is IPV and OPV. So that was a very brief discussion or some thoughts about the basics of polio for this session, and there will be more discussion on it. Thank you very much, and if you have any question, any clarification, you're most welcome to put across. Thank you.
Thank you so much, Nasser. So if you have any questions, you can put them into the chat box or on the link for the Slido link. You can also raise your hand. And we'd like to show one of these videos that you're seeing on the slide on the 2 vaccines. So I'll get that up as you think of any questions.
Polio is a disease that causes permanent paralysis. We can't cure it, but we can prevent it. 2 important tools help to prevent polio, 2 safe, effective vaccines. One of these vaccines is given with just 2 drops into the mouth of a child. This is called the oral polio vaccine. The other is given with an injection. This is called the inactivated poliovirus vaccine. They both teach children's bodies how to fight off the polio virus, but they do this in different ways. The oral polio vaccine builds protection in the child's intestine. This vaccine not only protects the child who receives it, but also protects others around the vaccinated child. Several doses of the oral polio vaccine should be given to every single child in places where polio is a threat. The injectable vaccine builds protection in the blood instead of the gut. It helps to boost immunity and keeps countries free from polio. But it doesn't stop polio spreading between children, so it is not as useful in places where the virus is still circulating. We need the oral vaccine to stop the virus wherever it is found. Once polio has been stopped everywhere, the inactivated poliovirus vaccine will be used on its own to keep populations protected. Both of these vaccines have been approved as safe and effective by the World Health Organization. To do their job properly, they need to be given to all children, no matter where they live. Thanks to these vaccines, cases of polio have fallen by over 99% around the world. Let's vaccinate every last child. Let's end polio forever.
Okay. And I didn't ask before if Lorraine or Nasser had any comment on this video, but I do see we have some questions coming in. So we have a question from the from Qatar in the room with Cindy in Sierra Leone. And Nasser, would you like to answer this question, whether in the picture example provided, the micro-planning was at community level or what scope? I see you've written in the chat.
Thanks, Erin. I have already written it. Yes, thanks. It's a very good question, Kotor, for putting across it. Yes, it was a micro planning at the community level, because in that context, for each community, there were community mobilization coordinators, and they would be working along with the vaccination area divided by the health center of that particular area. And not only one team, it will depend on the population, because these were the areas very, that had very high density of population. So in one, local facility catchment area, there were about 10 or 15 or even 18 vaccination teams. For each vaccination teams, there was a micro plan for about 250 to 300 households with children of under 5 years of age. So this micro plan had for each team area a separate micro plan, and each micro plan was developed by the CMC, Community Mobilization Coordinator, under the supervision of BMC, Block Mobilization Coordinator, the guy who was standing behind that. And then above that, there is a district level structure and then sub-region. So that was a support provided by UNICEF, because the government system at that time was very, very overwhelmed. community level. Thank you.
Thank you, Nasir. And we have a question from Safia, and then I'll show another question coming in on the Slido, asking to clarify, when you said the reservoir is only in humans, can you please clarify when we know that the virus could also be shed into the environment that could genetically change to infect children with poor or low immunity? That's a question in the chat box from Safia.
Thanks, Sylvia, Sophia, for this. Yeah, it is more technical, so I would request my colleagues who are epidemiologists and they do the environment sampling. As a communication person, what I have learned from them, yes, it remains a human virus. The environment, and that's where it remains for a certain time till the time it gets another host. If the other host is not found by the virus should die down. So that's what I can say. So whether it is in environment, it still needs human host to remain live. Without that, it's not going to live and infect any further. So that's what, and I would request my virologist and then epidemiologist colleagues to elaborate more on this.
Thank you. Would anyone else like to comment on this? If not, we have a comment coming in on the Slido that I wanted to show from Harold from Sierra Leone, commenting that the social ecology theory suggests the need to alter political and economic trends.
Aaron, this is Lorraine. With regards to this question that has come in on the theory, we're actually going to be looking, absolutely, and we'll be looking at this tomorrow. Yeah, when we go into the behavioral components and breaking down the community engagement, etc. We will touch on this.
Excellent.
But in agreement, yeah.
Then we have another question from Douglas, asking which of the two vaccines are part of the routine immunization process?
Okay, this is Lorraine again. I will try and answer, but Mike Lawson's on the call. Lawson, are you here? I think he is, because we do use IPV for RI, but I think they might be using, I don't know if Lawson's still on the call with us.
I think he might have dropped off.
He might have dropped off. Then I will hand it over to Tommy, if you can help address that, or any of our colleagues who are currently working or from the MOH. You can talk.
I think this is a country specific question. Immunization program in each country. I'm not a EPI person, so I can't answer that question. So
it looks like Tabli from Ministry of Health and is answering in the chat IPV and OPV type 1 and 3.
And also someone tried to call my name out. I think there's someone else.
Yeah, it's Farhad, Lorraine.
Thanks, Farhad.
I don't claim I have the final expertise, the final opinion on this, but as far as I know, the routine immunization includes two, IPV, as Tabli, I think, mentioned, and OPV. And OPV is a bivalent now because type 2 was removed and was switched in 2016, was switched to BOPV. These are the two vaccines I used. And depending on the national schedule, it could be 3 OPVs and 1 IPV. Over.
Yes, that's right.
Thank you. Yes, Kago, go ahead.
Yeah. I just wanted to see if there's anyone from any of the Ministry of Health who would like to talk about that a little bit, because doesn't that also have to do with NIDs?
Yes, this is Kasim. I'm a communication, I'm a health promotion technical officer, the Minister of Health. We are using two, the OPV and IPV. OPV starts at 6 months and goes through the one month interval. That's at 6, 10, and 14. And at 14, that's when the child gets the IPV together with the OPV as completes the third dose of OPV.
Yes, it's only one correction. I don't think it's months, if I heard it correctly. It's weeks.
Well, it's, you can translate it in 2 weeks or months. I said 6 weeks, 6 weeks, sorry.
Oh, okay.
Yeah, 6
I heard
weeks,
months,
1.5
sorry.
months. 1.5 months, yeah. And then an interval of 4 weeks or 1 month. And then there are 3 doses.
Thank you. And I see Cindy in the room that Ministry of Health and Sanitation would like to add there as well. You can unmute. Go ahead.
Yeah, thank you for giving me the opportunity. I'm Umwawa. To answer to the question asked by a colleague, the first dose, there are 4 doses, but you have the first dose for OPV, you have the first dose at birth when the mother comes with the child for BCG. That is the time they give the OPV 0 dose. Then so you have the OPV 0 dose plus the 3 other doses that you take at 6 weeks. When the child is 6 weeks, that's the time they give the second. Then the third one you have when the mother brings the child at 10 weeks. It goes together with the pentavalent and the other vaccine, the Nemo and the rest. Then you have the other one, the fourth one, which is the child, which is at 14 weeks. That is the time when the mother comes with the child to be given penta, and they give again the IPV. We always give it the IPV with the pentavalent 3. So that's that. So the back dose was not mentioned. That was why.
Yeah, you're right. Yeah.
Can I come in? Yeah. Hi, Erin. There is a question. Yeah, there is Rita has a question. Actually, what is the difference between type 1, 2, 3 in terms of how they affect the human body? So actually, in terms of affecting human body, no difference. They all 3 affect the body in the same way. That is leading to paralysis. The only difference what we have seen their eradication has happened at different point of time. Like what we see, it was the type 2 wild virus which was eradicated first, and then type 3 and the type 1 which is remaining, like what we were discussing in the context of Pakistan and Afghanistan, which are still endemic. We find that type 1 wild polio virus. So this is what in a way answer is. And then there is another question that type 2 is eradicated. Yeah, Ibrahim has asked, type 2 is eradicated, yet we still have cases from the same. That is the eradication is of the wild polio virus. So what you hear is actually the vaccine drive type 2, and there will be more discussion on it. So when we talk about the type 2 eradicated, that is the wild polio virus type. So yeah. So you just hold on. There will be more discussions on this one. Thank you.
Thank you, Nasser. And we have one more question in the chat from Abel in Uganda. When do we determine use of oral or injection vaccine?
Come again with the question.
Jump in if there is nobody else.
And just to repeat one more time, and then we can go to Mariana. When do we determine use of oral or injection vaccine?
So the OPV is for the outbreak response. The OPV is considered to be the tool of choice. Prior to this year, it was monovalent OPV as a tool to stop the outbreaks now. And from what I understand, the NOPV will be widely used in Africa, but the outbreaks are recommended to be stopped with oral polio vaccine, either MOPV or NOPV. But regardless of which tool we're using, the main goal of every campaign is to reach every single child and to ensure the high level of coverage and high level of quality of the campaigns. So for outbreaks, I'm not talking about routine immunization, but for outbreaks, it's only OPV that is used to respond to the outbreak. Thank you.
Thanks, Mariana.
I think Kagwa had something he'd like to say on that too, please.
Come again? About the...
Oh, I thought you wanted to add to that.
I've been using oral polio, but with the routine, there's no option. Both of them are used. With RI, we use both.
Yeah.
No option. It's not optional.
And also, I remember when we were working on some of the materials, the key messages and training materials when we were looking at IPV, etc. I mean, there is that standard WHO chart that they make on recommendations of what's used when and at what age, etc. But at the end, it's all left to the discretion of the Ministry of Health and the country offices too.
And I see that the Ministry of Health in Sierra Leone would like to comment. Cindy, you're unmuted.
Yes, the indications for the two. For us in Sierra Leone, we are using two. The OPV is good, yes, it's nice for campaign purposes or CS. Then for our routine, we use both the OPV and the IPV. Reason being, for the OPV, we know the OPV is very effective and it targets the gut, the intestines of the child. But some of the viruses do escape. They go to the bloodstream. So in giving the IPV gives something like a 99.9% protection because the vaccine can enter into the bloodstream and attack some of the escaped viruses. That is why they are giving two, so that it can perfectly work. The two of them can perfectly work in targeting the virus.
Thank you very much. Do we have any other questions or comments?
Excuse me, I had a comment earlier. Yes. When there was a presentation showing demand, supply, and sustainability of these demands. I think as communicators, we need to also look keenly on communication during service delivery. Most of the communication strategies do focus so much on communities and pushing them to the health facilities. But we find that communication during health delivery is a bit, a bit poor, that it deters people from going back to those facilities. And therefore, we get dropouts. So I hope we need to do something and guide these health workers on when to communicate what and what to communicate to these people. Maybe we need some counseling cards for them. Yeah.
Kagwa, absolutely, and we're in complete agreement with this, and we can actually even see this globally when it's going on just with the current pandemic. Actually, when we go into the next presentation, where I'm going to very quickly touch on looking at the phases of all diagram that we will bring up, which will address exactly what you're saying. And you're 100% correct about that.
Thank you.
Okay, we have some comments coming in. That's also a gap in Sierra Leone. Any other questions or comments? on this section. And to note, colleagues, if you have questions during these sessions, you can raise your hand to make a comment or simply unmute your microphone, and we'll keep an eye on that to allow you to speak. And to raise your hand is on the participants menu. When you click participants, raise hand, and otherwise just unmuting is more than welcome. Okay, I don't see any more questions or comments coming in. Lorraine, I can hand it over to you.
Yes, thank you. Let me just bring up the screen over here. And there we go. Okay, colleagues, I would just like to take a few minutes to talk about the SOPs and the different phases of what happens during outbreaks or preparedness going into them. Before I do, I just want to ask, is there anyone present in any of these countries over here who's actually been through any of the polio SOP trainings? Okay, I don't see a response for that. So just to let you know that we do have another set of trainings that we do, and they're the standard operating procedures for outbreak response. Farhad could probably give you more information on that if we're currently doing them, but a few years ago we were doing them quite heavily. I do know that we also have presentations and slides on them if anybody is interested in looking through one of them, and we might even have it online in Agora. Okay. So this is just a map, just a small are currently going through, which is increasing, and an important reason for us to have these trainings that's going on. We have these standard operating procedures, the SOPs that were delivered, that were developed about 5-6 years ago. I believe we're in version 3 right now. This is done in partnership. We used to conduct trainings for these when we first rolled them out. At the beginning, I've also put all these tools, these resources in your Dropbox folder. But this is just an example of the SOPs, which are also on our online platforms and also on the GPEI. Okay, so I'm going to look at this from the perspective of our work and what we do, looking at it in more from the communication lens, okay, and looking at the various phases. So when we look at the outbreaks, we look at them in 3 phases. The first, of course, is the red one, which is what happens during when it's first called, and then looking at the enduring phase, which is 6 months. Farhad is in the room over here, and I know he would like to see some of these dates changed. And then, of course, when we look at maintenance, which we've just been talking about. So what happens when we actually go into the outbreak in the enduring phase, and then when we come into maintenance to move back into routine immunization, when we stop interruption. This is a schematic just to show you that the support that we give as communication officers, and when it starts in the beginning and how much you can see, which is the external communication part that's coming in, but then also what happens when we start shifting and moving more into the C4D component of it. I put a little note up there in red, just to remind you that this is not just the work of UNICEF, as we saw, and as most of you know in the room as health officers. It's government-led also. A big part of it is WHO, and then what is the component of it that UNICEF is doing in our external advocacy components, and then, of course, when we do the shift into the C4D part of it, okay? So when we look at it, as we said, there were the 3 phases. There's the outbreak phase, the enduring, and then, of course, the maintenance phase. But when we look at it as comms officers, as health officers, we look at it and how our approaches are in our communication strategy and how we address that vary or change. Sometimes they are intertwined. But at the beginning of an outbreak, as most of you, we had 89% who said they worked on campaigns, etc., can see that at the beginning of the outbreak, when there's a very high peak over here, we have to increase the risk perceptions of what's happening. And so how we channel our information, will vary, okay, compared to when we start to go down on this curve and come to the other side. So this is just, we have 2 slides over here that show you what we are doing at this early part when we go into the outbreak phase. And you can see that the standard operating procedures will tell you what are the things that we need to keep in mind, the checklist that we look at when we look at it from an external communication perspective and when we look at it from the C4D perspective, right? So you can see, like, identify our media people, which we probably have already done, our landscape analysis, the protocols, the press briefing, et cetera, et cetera. And there you can see again, when we even talk about these press briefings and these releases, again, where we said we have government and we have WHO who take a big lead in that part. And then the C4D side that we start to look at when we're doing our engagement and stuff. And this shows a timeline that starts from 24 hours. And I can't see what it says on the bottom of the screen over there, to 72 hours, which is literally less than a week. Just a reminder that also when we did do these SOPs and we originally, and this is how we started the development of this whole emergency response team that sits in Geneva, was how do we get people out and deploy them into the field very quickly so that we can come into countries and give that support that comes from behind. Okay, next slide. And then this is a slide that shows from 72 hours going into 14 days. So we're still in our outbreak phase, and you can actually see that when you're looking at external comms, we're kind of reducing an increase of what's going on. This is, we put this image in here because, as I said earlier, how we respond is very different. So in the outbreak, we actually do most of our bombardment, right? We're using all different forms of channeling. We want to get the information out there as quickly as possible, and we're moving at a very quick pace. And so we use multiple forms of channeling the information to get out there. You can see there's a lot of IEC materials shown on this to bring out a lot of information. We're using community engagement. We also have these images on the bottom where you can actually see paralysis in children. I know as a health promotion officer that a lot of times when we speak, we try and show more of the positive messaging to help promote people to raise awareness rather than using negative. But what has been also proven to work is showing images sometimes that bring more of a shock effect in the beginning. Okay, so this is the enduring phase of an outbreak, which is where we're now going into a lot of different things that are going on. There's a lot of information that's coming in. There's a lot of data. We've done a lot of social data that's coming in. So now we can actually target more and go after very specific groups that we're looking at. So when we channel our information and when we work as comms officers, we also start to change the approach of what we're doing. And this is an image to show you that when I come back to this, when we looked at the high peak level, where we were using radio bombardment of information, etc., and we're moving into the enduring phase, we have a lot more data that's coming in, and so we can start bringing in a lot more of our community engagement, which, remember, takes a lot of time. It's also quite costly, but now we're going on after very specific groups, and that's what happens during the enduring phase. And then the third one that we talk about is the maintenance phase. And this maintenance phase, if you look at this graph that we have over here, is when we're starting to shift to go back into routine immunization. But we also have to be careful of this because this can be deceptive, because it looks like you might not need as much as you were using in the beginning with your approach. But the problem over here is if we do not nip this one very quickly, this is when you see the reoccurrence of outbreaks coming on. Okay, and then of course the IEC materials to the right that shows you is when we're going to vaccinate, protect your children, and also changing the image over here where you've seen we've shifted a little bit now from the drops, which we're using in our to the IPV phase. We have this slide to show you that, as we were just speaking, everything has shifted, right? But as I said, be careful of that little population down over there because they could be some of the hardest to reach population. And this is where you'll see a lot of things happening with rumors that are going on, what is going on with social media, et cetera, et cetera. So this is just to take you through the different phases very quickly. We do have trainings for this. They usually take a couple of days, but just to show that as comms officers, our approach in the outbreak can be quite different from what we are doing when we're going into an enduring phase. So this is the schematic that I wanted to show you. This is not a theory or anything. This is just an image that we have to show you what goes on during the vaccination process. So this has come up, and I think Kagwa brought this up in one of the conversations he was just talking about, or it might have come up in the chat when somebody else brought it up, when we look at the ecological model. So if you look at these circles in the background, you can see that kind of fits into our whole theory of change, or how we look at the socio-ecological models of when we look at the individuals and when we look at the communities. And then when we look at the bigger picture of the health systems and the political systems that are all combined, that makes change right in the middle, which is the parent and caregiver, right? And we'll talk about that a little tomorrow when we look at the behavioral analysis. So if you look to the left-hand side of this, where we have number 1, number 2, and number 3. When I look at this and I look at the middle and I think about how do we create change over here and how do we bring this knowledge? This is where you can see a lot of the strengths of the polio program, right? The knowledge and awareness. When we look at those different phases of what we are doing, and how do we intent to vaccinate, and how do we prepare them so that by the time we are running our campaigns and we come door to door, we increase that rate of uptake of vaccine. But if you look at the right-hand side, this is where we start to look at the routine side. And so when we developed this diagram, we actually worked in a headquarters over here with our colleagues in the immunization side of it on the C4D with Benjamin Hickler and all. And you can see the changes that may occur over here. And when you look at this individual, we're not looking door to door anymore, right? We're actually looking at our health systems and taking this person and when they have to go to vaccinate. So there's things that people look at, and this is the value of what they look at. It could be a cost issue, right? It's a vaccination. It could be an effort issue. It's getting to the point of service. And then when you look at the point of service and you look at what we're doing, it's like you might come for the first vaccination, but what happens vaccinated, right? And so this has an effect on our systems too, because when we look at that maintenance phase, this is exactly what's going on. And as someone mentioned, one of our colleagues mentioned, let's not just focus so much on the community level, but what are we doing with the health workers, right? Are we making sure these people have the right IPC skills? Do they have the right empathy that when you do come to the clinics, when we were talking about the supply and demand, we can have all the vaccines over there, but are we encouraging them? Are we giving them the support to make sure that they're coming back for the second vaccination and completing the dose? And this is a big issue over here, because if we cannot do this and we cannot support this, then we will find ourselves falling back into what's going on the left-hand side. I think when we look at this with the polio program, and we can look at exactly what's going on globally with vaccination and the intent to vaccinate, or how do we keep this encouragement on, we can just look at exactly what's going on with COVID-19 and the COVAX situation. So just to remind you, everything we talk about, these phases, we have these tools available for you. This is an example of what's in your folders. This is the communication strategy that was made for the polio outbreak response. You can see it comes into 3 phases, and it will walk you through and give you support on what you do in those different phases when you are designing your plans. This is an example to show you that we also have IEC materials that have been developed for you that you will use in different phases when you design your strategies. Everything that we do also has been made so that you can customize them for the country programs. And this is an example to show you also of the training packages that are available that follow the same stuff. What do you do during an outbreak and during, and then of course, beyond polio. Okay, so that's just a quick touch on the SOPs. And with that, I'm going to hand it over to Aaron or to see if we have any questions.
Thank you, Lorraine. Yes, I see we have a hand raised, and I realize the hand raise might have moved in Zoom. So if you'd like to raise your hand, it's under reactions. You can raise hand. Ibrahim, I see you have your hand up.
Yeah.
Please go ahead.
I want to thank Lauren for her presentation. But I'm a bit concerned because I've not been able to see anything on issues around misconceptions and rumor management. And I think that's a big concern for us here in Sierra Leone, because most of the time when you roll out these health campaigns, these health programs, we have lots of rumors, misconceptions, and myths, and all of these at times, impact, our communication, which we roll out. And I think it will be key if some of these issues may have been captured or are captured in the SOPs. And that's my submission.
Yes, absolutely. And you know what? When you're speaking about the SOPs, we only went up to 14 days, but and that's something I actually had sent an email to a colleague. Okay. If you look beyond the 14 days, when we're going all the way to the closeout, the enduring phase, that is where we use a lot more community engagement because of this, right? And that's why we change our approaches, and that's where all this data is coming in. So you will see when we talk tomorrow, a lot of it is like, how are we making these informed decisions that are data driven, right?
Okay.
Yeah. Yes, and actually Kashan will also be presenting tomorrow, where we will look a lot at misconceptions and that information that comes through. But you're absolutely.
Thank you.
Aaron, if we don't have any other questions, or if we can wait with some of the questions, because we're actually going into our break time, and colleagues have been sitting for like 1.5 hours. I prefer if we do that, and then when we go to the Q&A, we can bring them, because we're already over by like 5 minutes, right?
Excellent, yes. So we have one question coming into the chat. Should we, and I think Cindy is either raising hand or giving some feedback.
Yeah.
Would you like to hold these? Okay.
Yeah, go ahead, Aaron. Didn't mean to interrupt you.
Okay.
Yeah, I think one is just when you talked about the 3 phases for polio, I was thinking you mentioned something like AEFI. I did not see any AEFI because we know we are dealing with the injectable, which is the IPV. So I don't know why AEFI, nothing like AEFI, because that's something again we need to talk about.
Okay, Cindy, I didn't hear you very clearly. Can we bring this back up in the Q&A when we have a little more time?
Okay.
Which will be after Tommy presents. So please hold your thought and we'll come back and address it. Okay. Or from Cindy's room. I'm not sure if it's Cindy or someone from their room. Okay.
Thanks, Cindy. So you can hold on to that question or write it into the chat, and we can come to it at the Q&A later on. And there's also a question from Martin about would like to see the space for the faith-based organization, or what is your view?
Yes, and we'll talk about that, and we can bring it up in the Q&A, but it will come up tomorrow when we look at the SCM model. And absolutely, it's part of the community. And we can discuss that more tomorrow too.
Excellent. So it looks like we can continue to discuss these questions in the Q&A session, and we'll be going into a break now, Lorraine, for 15 minutes.
Yeah, we're already over by 10 minutes. So if we can take it down to 10 minutes so we leave plenty of time for Tommy and for the Q&A, that would be very helpful if everyone, if you don't mind, and we just take it to 10 minutes.
Excellent. So we'll take a 10-minute break. So we'll start back again at 10 minutes to the hour, and I'll put a timer on the screen just so that you can have a sense for when you should be back on your computer. So please take a break, get something to drink, walk around a bit, think about what we've been discussing, and we'll come back at 10 minutes to the hour.
Thank you, Aaron.
Thank you.
This next presentation talks about crisis communication, and it's a sort of introductory presentation. And why we are bringing it on for this training is a couple of reasons. First of all, We know that in the COVID context, there's already a lot of rumors, misinformation circulating globally in social media, digital media, offline, online, that might have impact on polio campaigns that are door-to-door campaigns. So that's one reason. Second reason is obviously the fact that we are bringing the novel OPV2 first time as a new vaccine. So the GPI has decided that as part of the NOPV2 preparedness, each country that introduces NOPV2 will have to have in place a crisis communication plan. That's part of the requirements in the checklist that you may have already received. So this gives you an introduction, and then also a note that if Uganda or Sierra Leone, either of you need more support for preparing a crisis communication plan, then let Mariana know in the Outbreak team, so we can organize that kind of a support. As I said, this is just some sort of introduction to the topic, and this is also directly linked to what Kassan will be talking tomorrow about rumors and misinformation management. And it's also linked to the vaccine-related event plan that has to be in place in the country as a requirement for the NOPV2 introduction. How do I change slides? Erin, I can't.
On the bottom left-hand side, there's little arrows that you can.
I don't have any arrows.
Or just clicking.
Oh, there you go.
Green. There you go.
So the definition on, there might be several definitions, but I just wanted to put this in here that what is a crisis? And it can be all kinds of different type of crisis, but in the polio context, we can think about what is written here, that the crises occur as a culmination of specific but separate issues that, when taken together, can limit the ability to achieve the overall objective. So if our objective is to vaccinate all children under 5 in a campaign, we can start thinking about what could go wrong that would prevent us from achieving our objective. And they could be issues around operational issues. They could be issues around communications. There could be issues, and as already mentioned by many of you, about misinformation, rumors that are circulating, or an issue that we have not appropriately communicated with our audiences so that they understand the value of the polio vaccine, and if they have misunderstood the messages. So a combination of factors, when they come together, can create a serious situation where we can no longer achieve our objective. And I just give you an example. Last year in April, I was in Pakistan, and the country was just launching an NID, National Immunization Days, and it was targeting an extended age group, so children under 10, for epidemiological reasons in that region. And what happened is that the campaign had to be halted after the 3rd day because a crisis occurred. And what created the crisis? It started by a manufactured, a political group in the country that was against the government services and against polio vaccination, and where it shows young boys were rushed into the hospital, and the narration says that these children were sick because they received the oral polio vaccine. It then started circulating in the WhatsApp circles, but it quickly jumped from out of the WhatsApp circles into the open social media circles, and from there into the local radio stations. And it was also a combination of mosque announcements that were also disseminating the same misinformation that OPV vaccine causes sickness in children, And if you don't take your child to the hospital immediately, he or she might die. So this was a combination, orchestrated effort. Well, misinformation and rumor created a major crisis for the polio program that then resulted in attacks on a health facility, and the polio vaccinators could no longer safely circulate in the communities, and that's why the campaign was halted. And then the efforts to get back into building the trust in the vaccine has taken a long time now in the country. So this is an extreme example, but it just tells you that it is a number of it could be a number of operational issues, such as the vaccinators are not well trained and they don't visit all the areas they're supposed to. And then it could be linked to misinformation and rumors that are causing a lot of vaccine refusals, and therefore we can no longer achieve our objective, and this is a crisis. So in a crisis, the right message at the right time from the right person can save lives and can save the program. So this is a sort of a catchy message that is really, really important. Actually, it is important to be prepared for crises with messages that are prepared in advance, that are obviously strengthening the trust in the program and in the vaccine. And it is important that it is timely, and we'll talk about that later in this presentation. And also that we have the right people that that actually then communicate this. This is from the CDC Crisis and Emergency Risk Communication document, where there's 6 sort of a simple and key sort of points that you should keep in mind in a crisis. Number 1, be first. So if you leave the vacuum for information, the misinformation rumors will just be further amplified and disseminated. So be first to actually correct and correct the rumors and misinformation. Make sure you're right. You have correct information. Make sure you're credible, so your spokespeople are credible. Be sure to express empathy towards, if let's say there's in a case of AFVI that is not because of the OPV but about another vaccination, but it is linked in the people's minds to the polio vaccination. Empathy to the people that are affected, that is really important. Promote action, and this just means that, because our goal is to vaccinate every child under 5, is to reassure them, express empathy, present correct information, and then promote continued vaccination, as this is not, we will try to, and we will have to try to achieve our objective so that we can protect every child against polio. And show respect in your communication. Communities are not just your target audience. They are human beings. They have their feelings. They have their concerns. So show respect when you communicate with community influencers, for example, when you're addressing a situation. I mentioned earlier that the vaccine-related event plan has to be part of the NOPV preparedness, and this is normally supported by WHO and CDC, preparation of this plan. And the VRE plan is then directly obviously linked to the crisis communication plan. So all these plans should be in one country level plan when the planning process has been completed. So the C4D plan, communication plan, includes the vaccine-related event plan and the crisis communication plan. So what is a vaccine-related event? In polio, we rarely, if ever, I have worked for 6 years in polio now, I never seen any adverse event following OPV. All I have seen, or maybe it was in Nigeria a couple of years back, 10 years back when I was there, some mild fever, but any adverse events are very, very rare in OPV, and that's also something we expect will be the case with NOPV. However, in crisis communication plan, vaccine-related event plan, you need to be prepared for any eventuality, and also understanding that there could be some other vaccinations that are caused an adverse event that people crisis for you. There could be a new study or experimental data related to vaccines or immunization. There could be a report in the press or a local rumor about vaccines, or there could be a change in status of vaccine, which we don't obviously anticipate in the case of NOPV, but this is just from the WHO definition of what is the VRE. A VRE is, so it's linked to negative perception of the vaccine safety, and it is a major event that can adversely affect vaccine acceptance. And that's when we enter into a crisis, because we will not be able to achieve our objective, which is to vaccinate every child under 5. So all this information is critical to understand and then be prepared to respond to this. So this chart just shows what we call a spectrum of engagement with communities. And it's goes from just informing one-way communication to the community to shared leadership with the communities where there's a strong bidirectional relationship, and the communities really feel as they are part of the program itself. And why this is important in crisis communication, because often first thing we think about crisis communication response is, hey, let's do a media release, or let's put a Facebook posting or something like that, which is important. They are part of it. But even more important is to think about how do we, if we have crises that are localized in communities, how do we engage those communities in the crisis communication efforts to resolve the situation? And this shows that we often we forget that we are not in C4D. We are not just to give information to communities. We are to work with communities, understanding their concerns and supporting them any way we can. And so the best practice often is that the community that is involved in decision making for the health, and in our case in polio campaigns, is more likely to own the immunization activities and promote shared accountability to help meet health coverage targets. So this is important to consider as part of the crisis communication plan. How do we do offline, on the ground engagement with communities to manage a crisis if it happens? And it's here it says that often there's a gap because the EPR communications plans or VRE responses are happening at the outreach level, where we only communicate information but we don't engage, which is in the spectrum on the right side. So what is the crisis communication life cycle? There's 4 elements to it. The first phase is the planning and preparation, where you put together your crisis communication response team. I was recently in November in Congo Brazzaville, where they were going through the same exercise, and they established a team. It's led chaired by the EPI manager, and then there will be representatives from UNICEF, WHO, and other partners. So that team is the core team at the national central level that is really making decisions when it comes to a crisis response, understanding the appropriate response and deciding on what the response is. At the same time, there has to be more lower level response teams as well, particularly in Congo Brazzaville, where there's a lot of areas that level there's a need for sort of a district level response teams that can respond to a crisis offline on the ground without necessarily waiting for the central level decision. So this was sort of the dynamics that Congo Brazzaville found very important. So these crisis teams have to be connected and they understand how they work together. There's procedures in place. It's important also to prepare for a crisis by running simulations to test your processes and how would you react to situations. And there's a possibility to get further support for this from UNICEF. So Mariana would be the contact person if either of the countries would feel that these simulation kind of exercise would be helpful for them to understand better how to prepare for a crisis. And prepare your stakeholders and spokespeople. So, and this is important not just to have a central level spokespeople, but more decentralized structure probably is more helpful, because some of the crises can be very localized, don't need a national response, but need a local quick response. And that's why these structures and spokespeople should be set up in early on. When the crisis happens, whatever happens in the situation, you assess the crisis, and then you really important decide appropriate response level. And we'll talk about this a little bit later, because sometimes if you do the wrong assessment and you react in an inappropriate way, you can actually just make the crisis even worse yourself. The crisis management, so when the decision to respond is made, you, as I said earlier, would be good to have a key message document to reinforce the messaging around the safety of the NOPV2 vaccine, and then implement the tactics, whatever are the most appropriate, to mitigate the impact of the crisis. And you correct the falsehoods or rumors that are circulating, and you limit the crisis from getting bigger. And you have your monitoring escalation plans. And here, each country is different in terms of the capacities, but I think Kashan will talk about this more tomorrow. How can you monitor the social digital media, and how do you then prepare a response to that? And then decide when the crisis is over, when we are ensure that there's no further impact on our ability to achieve the objective, and then inform internal teams. And at the end, is to evaluate the crisis response and the whole system you have in place. How did the crisis response team operate? Did we mitigate the crisis at the right time, or did we wait too long? And then check in with all the stakeholders and those impacted, and prepare for the next crisis. And this is basically just to be prepared. Obviously, we hope that there won't be any kind of event or information or rumors that circulating that is impacting our campaign. But this, it's always good to be prepared, and that's why this plan, preparing the crisis communication plan, is important. We have worked with McCann Global Health to look at what would be the sort of the key indicators to look at when you assess a potential crisis. So number one is the risk to campaign success. And so do we have the ability to safely deliver NOPV2 or other vaccines? This could be any vaccines, other vaccines. Do we feel that there's a risk that we cannot safely deliver NOPV2 or any other vaccine that we're working on? The reach and scope. What is the number of people reached or impacted by the potential crisis? So if there's a local village leader in community X that has heard a rumor that the NOPV2 vaccine is linked to COVAX vaccine or COVID, and it's not good for the children, and refuses and makes the entire village refuse. How do we make sure that this rumor is not amplified by this village chief and circulating to other villages and actually making a bigger crisis? So we have to assess that. Is that possible, or is it likely that we can locally, through community engagement with this village chief, assure the person that the vaccine is safe and there's no risk to children. This is the only way they can protect the children from polio. So we have to make that assessment, and then that then determines the appropriate response. And I already talked about it, so I won't repeat that. And then what is the response capacity? So I talked about the central level team, but do we have a good team at the local level or district level to respond to this crisis? Do we have we informed them how to set up their team? What is their role? Do they have some prepared key messaging that they can use to respond to a crisis? So making sure we make that assessment. Community and government confidence. So is the community and our government are at risk of losing confidence in NOPV2 or polio vaccination overall? Let's take a community let's take a religious sect that is spread all through the country. If one sect leader from this religious sect refuses the vaccination and does, is it possible that then that sect leader will also mobilize the other sect leaders in other parts of the country to refuse the vaccination? So this thinking and assessment has to happen based on all these 5 different criteria to determine the appropriate response. So these are some of the considerations I mentioned earlier. Sometimes proactive communications can draw more attention to the issue. So is that attention helpful or harmful? So really making the right judgment call in a potential crisis is critical. Have we included the expertise and perspectives of issues experts? So we have all the right people, vaccine safety focal points, GPI representatives and government representatives ready and involved in assessing the situation and determining the response, appropriate response. And what happens if we do nothing? If you make the wrong judgment call, a small situation that is seen as a crisis might just not get expanded anywhere. And if we do nothing, we might just be fine. What happens if we wait a few days to respond? Often in crisis communication, the rapid response is seen as the best. But if we wait, is there going to be more damage to the program and the campaign than if we don't wait? Are there other facts or events that you should wait for the outcome on before deciding? Is there additional expertise that we have to seek before we make the decision? What is the risk benefit of waiting any time at all? So these are all critical questions when the team is in place and if there's a potential crisis, to make the judgment call on the appropriate response. Because if you don't have the appropriate response, the first sentence there, you might actually be drawing more attention than it actually is. And there's a sort of a protocol for definitions of and this is something that is linked to the simulation exercise that you haven't done, but we can probably provide that. And if you think you wanna have that for your team, please contact Mariana or myself directly. But looking at on the left side, the 5 indicators are there, and then based on the assessment, you can categorize them either in the low risk, medium risk, or high risk. And then this categorization gives you guidance on how to respond and what is the appropriate response. Obviously, if you're in high risk on all the indicators, the response has to be quite robust. If you're on low risk or all the indicators, maybe the first thing is to consider, if we do nothing, maybe nothing will happen and we'll be. So on the right side, there's a reminder, and this is some high-risk scenarios. Let's say there's a vaccine-related death of any kind, rumored or true. maybe there's a rumor that a child in a village died because of the OPV. That could get out of our hand and swell really quickly and cause a lot of refusals and further misinformation circulating. Any kind of side effects that are, again, true or rumored to be part of the polio campaigning can cause also, should be also something we take it very seriously. If there's a violent attack, like in my example from Pakistan, the whole campaign had to be halted because even health workers were attacked because of the rumors circulating. Global reputational risks to the GPI partners or the government as any kind of a serious situation that we have to look at. If there's a vaccine pause or recall, which will not happen, but if there's an uncontrolled outbreak due to vaccine failure, which is not going to be the case. So these are just some potential sort of red flag scenarios where we are automatically in a high risk scenario. The last slide tells you sort of an anticipation example of vaccine refusals and how things can evolve over time when different specific things come together. And these dates are not probably accurate, but they just sort of illustrative. So we all know the AFRA certification happened in August. And so there is this some level of awareness that Africa is wild polio free. Vaccinating against polio again, people might be confused. Why are we still vaccinating against polio? Because we just were declared polio free, but it's the wild polio virus. So that's what people don't necessarily understand, that there are different types of polio. NOPV2 receives EUL recommendation, the emergency use listing, and that was in global, and maybe it will enter also some country level media. NOPV2 is introduced in country B. It's successful with minimal vaccine refusals. COVAX vaccine receives EUL recommendation and FDA authorization. So there's a global, regional, local media is consumed by this news. NOPV2 is noted as the only other EUL recommended vaccine. So then there's a linkage now. Okay, EUL recommended vaccine NOPV2 and COVAX vaccine. And in country B start mounting, and there's a conspiracy theories about COVAX vaccine and NOPV2 vaccine, and now we're reaching already about 1,000 people every day in social media with high engagement in comments and shares. And then that goes over to influential community leaders in country B. They cast doubt on all vaccines, and they call for NOPV2 refusals as rumors swell. So do leaders' engagement on these issues. So this is just a sort of an illustrative thing. And then at the end, there's a reported 22% increase in the vaccine refusals in country B. So this is totally illustrative, not a real scenario, but it just shows how in the COVID context, when we're coming in the global context, where rumors are already spreading very, very fast in the social media, particularly about COVAX vaccine, and even here in the US, the people's hesitance to actually vaccinate against COVID is very high. So these could be quickly linked to NOPV as a novel new vaccine that is being introduced, and it can quickly spill over from online to offline to influential community leaders, and that's when we come to in a major crisis. And if we're not prepared for this, then we will fail the campaign and we will fail our efforts to reach our objective. So that's just an introduction to the crisis comms, and then I just repeat one more time. If you need more guidance, as it is a requirement for the NOPV2 introduction to have a crisis communication plan in place, and the verification team checking your plans on that. So if you need guidance and more support on preparing that plan, we can engage an agency that has helped us to prepare all these materials. And please contact Mariana or myself directly so we can see how we could organize that. So thank you very much. And if you have any questions, I'm here to answer.
Thank you so much, Tommy. So I'd like to open up the floor, hear from you if you have any comments, questions for Tommy. Please feel free to write in the chat. I see some comments coming through into the chat box. You can also unmute yourself if you're able to do that, or use reactions to raise your hand, and I can be sure to come to you and give you the floor to speak and ask your question to Tommy or give your feedback. Yes, Miriam. I think you are, let's see.
Thanks. Is that okay?
Go. Yes,
yeah,
excellent.
Thanks, Erin, and thanks, Tommy. My question is around the actual communicating of a crisis. When we had the MR campaign last year, we noted as the communication team who wanted to say something that those decisions are not necessarily in our hands. They tend to be political or higher above the comms team's control. So whilst we might have advice and things that we think we should be doing, it needs to be noted that if we are not in control of a situation, i.e. don't have the power to discuss it, it makes it difficult for us to implement what we're supposed to do. And I'd like my colleagues Tablé and Kassim perhaps comment on that as well. The politics gets involved in that, and sometimes that power is taken away from us. Thank you.
Thank you, Miriam.
Oh, I can give I had the same situation in Pakistan last year, or the UNICEF country office had the same situation. So they had only a central level government control, and there was a person in place, a prime minister's advisor, who was in charge of the crisis communication. And his decision was only have central team in place. And this crisis happened in a city called Peshawar, which is in a different province. And the provincial team was ready to respond, but the central word was no, wait until we arrive there, and we're gonna do X, Y, Z. So there was a gap of 8 hours from 10 a.m. to 6 p.m. and the campaign didn't respond. They were ready with the messaging and they had everything lined up so that they could start communicating the corrective message about polio vaccination and polio immunization, but they were not allowed. So that was, from that experience, I believe they have now changed their protocols. So the provinces have more autonomy. So there's a provincial crisis communication team that works with the partners at the provincial level, including UNICEF, and so that they can have a more appropriate response and timely response. So that was seen as something that they learned from that experience. So maybe, and yes, I can see the frustration in UNICEF staff, but yes, the government is in lead. So I don't think we can change that, but at least we can advocate for, which is also a recommendation from the Congo training we did, that don't just set up a central team that every more effectively addressed locally, rapidly by local teams. So make sure those teams have the authority and understanding of how to respond.
Thanks, Tommy. We have a question in the chat from Ibrahim. I'm sorry, from Sierra Leone Ministry of Health and Sanitation. Ibrahim writes, proactive communication draws more attention, but don't you think that research is key in all of this to get it right?
Yeah, but I totally agree with that. But I think the preparedness is key. So preparedness for a crisis, I think, is really, really critical. As I presented the sort of the introduction to the topic, and then the assessment of the seriousness of the crisis based on those indicators determines the appropriate response. So whether it's proactive or whether, as I said in one of the slides, maybe if we do nothing, we actually are doing a better way to manage the crisis. So I think those are the key: the assessment, preparedness, and then the judgment to make the right call, whether we should have a proactive call and what type of proactive response, whether we go for national response, whether we go in a local, in one province or district community radio response, or whether we do nothing. So all these are judgment calls. Nobody can, I think, and that's why it's key that the team is in place with the right people and they consult the right technical people to any situation. And that sort of is the research you're doing, because you're in a crisis, so you don't necessarily you can't really set teams out, but obviously you have to understand the situation, assess it, and make the right judgment call for the appropriate response.
Thanks, Tommy. And I see, Tabla, you have your hand up. You can unmute and ask your question.
Thank you, Erin and Lorraine and Tommy for moderating this session. Mine is just a rejoinder on what Miriam, my counterpart in UNICEF Uganda, just mentioned, and that in terms of crisis here, the government takes the upper hand, and of course, the level is always high. For instance, if we are to declare any outbreak in the country, already now we know that Southern Sudan is a circulating virus, vaccine-derived polio virus, but in case it crosses into Uganda, it's not us to announce it. We have to sit as the ministry, and it's the minister to inform the head of state, who is the president, then who has to declare that now let's go ahead and respond. But of course, for us, what we do as with our C4D counterparts and in UNICEF and WHO, we continue making the preparations. But coming out to really respond directly, we have to wait until the highest authority has said, please go ahead, and then the National Task Force chairperson, and then our pillar. So it takes, there's a lot of bureaucracies in terms of responding to crisis in our country, because we must abide by the rules and regulations of the law. So thank you so much. Over.
Thank you, Tabley. Any comments or feedback from Tommy or facilitators? We also have some more action on the chat box. Abel writes from Uganda, as a communication team, we are expected to be ready to answer questions from the beneficiaries regarding vaccination. What are the likely adverse effects after vaccination, apart from high fever, as you mentioned, Tommy? And do we have any written protocol on how to address adverse effects by health workers?
Yes, and so there are documents we can provide, and honestly, I'm not a medical doctor, but I've worked for polio for many years now, and slight fever, not even high fever, is the only thing I've ever heard of being a AFI from OPV. So these are extremely rare. But the issue in my topic was that sometimes in people's minds, if something happens to a child under 5 at the same time as we are doing a campaign, rumors could start, oh, that child got really sick because he got the OPV, but it has nothing to do with the OPV. Maybe he never got it. So the rumor and misinformation can sometimes cause these situations. But as a polio worker for many years now, I never seen any serious adverse effects from OPV, and I don't know if we have any doctor under the call, but they are extremely rare. So, but there's a Q&A Q&A documents and frequently asked questions that are already in place as a standard tools for polio topics. So I'm sure they include also how to answer questions about any side effects, but they are extremely rare. So I don't know if there is from Uganda or Sierra Leone team anybody who is more medical background who could maybe add to that.
Would anyone else like to comment on whether there are either in the chat box, or you can raise your hand about whether there are written or about the adverse effects? Tabley mentions OPV is one of the safest vaccines with very rare adverse effects. And Miriam, go ahead.
On the AFIs, it's my understanding that when they do training with the health workers, one of the modules is based on AFI, looking out for AFIs and how to respond to them. So to answer Abel's question, there's usually in every training for whatever vaccine is being brought in, there's always a module on AFIs and what to look out for. So in terms of polio, like Tommy has said, there's not really much to look out for beyond fever. But for instance, when we did MR last year, there was a longer list of potential AFIs, from swelling on the arm from the injection to, maybe a fit or something like that. But it's usually done during the training of the health workers when they do their full module training. And then surveillance teams, of course. Thanks.
Thank you, Miriam. And Sydney from the room mentions no mention of AEFI for IPV.
The next question from Ibrahim is good. He talks about the health workers themselves can be part of the cycle of misinformation and crisis, maybe because of their biases and if their motivations are not clear. This is true, and that's why for the NOPV introduction, Lorraine has been working with the NOPV working group to prepare this frontline worker training modules for supervisors, so TOT level training that should be then cascaded to the lower level frontline workers, so that we are clear with them and we educate them about the vaccine, so that we could minimize the misinformation and making sure that the health workers, frontline workers, don't become part of the problem. So this is really important, because it's a new vaccine and people can start talking about it, and in the health workers themselves can start creating rumors about it, and then we have a big problem in our hands. So this kind of a cast when we come to the NOPV introduction. Lauren, you want to add something to that?
No, Tommy, absolutely right. And I think Sean is going to touch on this tomorrow, but it is something that we promote to be part of the feedback loop.
Thanks, Lorraine. Thanks, Tommy. And we have one more question in the chat box from Rita. Rita comments about the growing public resistance to vaccination that's being fueled by myths and misconceptions. People who were previously allies, like religious leaders, are now up in arms against vaccination, as was seen in the example in Kenya when they decampaigned HPV. And now in Uganda, some religious leaders are anti-COVAX. So Rita's question is, how do we effectively address this increasing misconceptions and resistance to vaccination? And I see Miriam in the chat box has given some feedback on this. And Tommy, if you'd like to add.
Yeah. Well, maybe you should read what Miriam says there.
Sure. We need more regular engagement with our religious leaders to address misinformation and disinformation. We usually only engage them when there is a campaign, but we need to set up a structure or system where we're engaging with them more regularly.
I agree. That's what I agree 100%. And also when it comes to NOPV2, so there are 3 requirements by the country that will be verified, that you have an advocacy plan. Mm-hmm. So the advocacy plan really would touch on the religious leaders and how do we advocate in advance with this particular influencer group to bring them on board with NOPV vaccination and might as well be COVAX vaccination. So understanding the value of vaccination and being supportive. So the advocacy plan has to be in place. So this would be under that. Then the crisis communication plan and the integrated C4D plan. So I think there's no magic bullet for that, and I think Kashan probably talks about how exponentially the misinformation around anti-vaxxers are up in arms now. They have good ammunition to start spreading misinformation, and actually it's so disheartening because a little personal story. I have an older brother who's already like 65 years old, and he keeps sending me links to all this misinformation about the COVID crisis and that it's a fake crisis and it's and then the vaccination is not effective. And he's an educated man, so I don't know how some people are more prone to follow this kind of information, but so it's so out there. So we just can only fight it with the correct information and using our communication and community engagement strategies to involve as much as possible the key influencers and have the right information countering as much as possible through credible organizations, credible spokespeople. So I think overall that's the strategic approach we have, but it's a big battle, definitely. Thank you.
Thanks, Tommy. And I think Nasir wanted to come in here as well.
Yeah, thank you very much, Erin. It's a very important aspect, about the religious leader and groups and their resistance, and then Uganda colleague has put across. I agree with what Tommy is really sharing here, and because there is no what we call the magic bullet to deal with them, because there is a variation and diversity of religious people, and also it depends who we are dealing with that. So it's all about very clear and evidence-based advocacy. If you allow me, I would like to share one experience in a few contexts I work. In that context, it happened to be the Muslim groups and their institutions and leaders where the main challenge came. And then, we realized that, we have to deal with them on their turf, rather than depending entirely on pure science and scientism and rationality and all those facts which we have. So it is about more than 12 years back in few countries like Bangladesh and Sri Lanka and India. So we realized that what is more matching with this. I'm just giving you example of Muslim religious different sects. I don't have experience of other religion. That's why it's very important to identify which is the religion we are talking about and which is the group and platform and sect or subsect within that. So that understanding is very important. So we realized that there is a Muslim group which is doing. So we did advocacy with them, and we went straight into Quran and Hadiths, and then we found out what Quran and Hadiths are saying about the preventive health. Obviously, there is no reference of vaccine in Quran and Hadith, but there is a very clear reference of preventive health. And you allow me, I will use the Arabic expression that is hifzan-e-sehat. Hifzan-e-sehat is the concept there in Hadiths, which talks about preventive health and measure. So we built on that whole concept there, and this is where we put the vaccination, and we demonstrated that it is not something which is challenging your faith or challenging your religion, and that's how it is. So initial discussion we had with the main groups, and then we organized 1.5 day consultations with different followings and school of thoughts, a workshop, and based on that workshop we developed a the advocacy document. We call it green booklet, and it is very effective, initially used in India. Now I think it is translated into many countries. So it talks only from the religious point of view and what are the importance of preventive health. It takes the reference from the preventive health and exclusive breastfeeding, hygiene and sanitation. For example, Islam emphasize on the purity and hygiene, and there is hygiene is half faith. That means that is the importance of personal hygiene in that one. So these were 4 or 5 messages we got identified with references of Quran and Hadith with number, and then it became really very, very effective. So we also realized that in many cases religious leaders and their institutions, they don't resist for the sake of resisting, because they have a constituency and people look at them and they are accountable to them, and they want to be convinced and very clear in the language and in a way they understand. So this is where the challenge is for us to have a advocacy and messages and material and content developed, and not, which should not be loaded with science. It should be how it can address their emotions and their system, and then the right kind of aligning with them. That's how we address behavior and messages. There will be more discussion what Lauren is talking about, that when we have this behavior and norms part of it. Yeah, religious leaders, and earlier also there was a comment whether faith leaders have that win. So we will wait for the session which will happen tomorrow. Absolutely, it is proven they are very, very important and one of the most critical stakeholders in this whole campaign, and we just can't avoid them. We need to understand them, and they are not one. There is a variety, and it will be good if we have that mapping. I demonstrated it. There is a presentation if you want to see it on communication initiative, which I was invited to present in 2007 May in CDC Atlanta for this stoppers things, if you are interested. So that is purely talking about that, how to map them, how to engage them, and what are the things you need to get and package it into the messaging when you deal with the religious leaders, not one, and there will be many. Sorry, it is a long speech, but I thought it will be good to come in. Thank you very much.
Thank you so much, Nasir, for all that rich experience. So we have a few things in the chat, and I also want to go to Kasim, who has his hand raised. And then I want to mention first that we can broaden now into the general question and answer. So if you have any questions on any of the sessions that we've gone through today, duty of care and do not harm, training in the context of COVID, outbreak response phases, SOPs, and role of comms, in addition to polio basics and crisis comms, please feel free to come forth with any of the questions from the training today.
Yeah, thank you very much. As we have been talking about religious groups, you realize that we also have, like we have informal settlements, we are having informal religious groupings. Those whom you may not even find their leaders. Some people prefer to call them the main religious groups you are talking about. So we have to bear that in mind if we are communicating. And I think we need to identify, because in Uganda we have encountered this, the 666, and they claim they don't have any leader. So you just have to choose the most talkative to be the leader, the charismatic leader, and then you engage that one. But what we have to do is to make sure we intensify our mobilization, education of communities, such that we encounter their rumors and misconceptions about the whole issue. So we have to bear those in mind. We have the mainstream religions, yes. They have structures, and we appreciate those structures. We can use those structures to reach their followers. But then there are those informal ones who are not in the mainstream of these other religions, and they also influence communities. They pull some of our communities away. So we have to intensify maybe community dialogues, community, education to ensure that they buy in. We do persuasive communication with the facts and encounter their misconceptions. Thank you very much.
Thank you very much, Yassine. We also have some comments, excellent comments in the chat from Ibrahim Sierra Leone, encouraging us not to lose sight of the fact that husbands and male partners can play a key role in rolling out vaccination services as we're developing crisis management plans. This was a gap in Sierra Leone when a study was done on routine immunization. And Emmanuel in Uganda is mentioning that the strategic communication elements and component in a business-like minded component of selling products is needed, concept we need to think through before and to get ahead of those who are creating myths and misconceptions. In Uganda, he mentions there is hardly one trusted voice, as used to be the case, and technical communication specialists and resources need to allow us projection of events before they happen, so that we can sell these ideas to communities in advance and work against rumors and myths, anticipate rumors and myths. So I think we have another minute for any other questions. We did have a question, Lorraine, that you wanted to comment on, I think from before the break. In Cindy's room, there was also a question from before the break about AEFI for IPV, and a comment on from Martin on Lorraine's presentation, seeing space for faith-based organizations, or what is your view in how to bring that into view?
Thank you, Aaron. Actually, while we were on break, I wanted to respond to the question that came up about the faith-based organizations. We will talk about this a little bit tomorrow when we're looking at the socio-ecological model. But what I also did was I went and downloaded this document from our C4D colleagues who are on the 10th floor, the main C4D team. Some of you might know Karida and Vincent and that whole team up there. And this is actually working with FBOs, engaging with faith actors for social and behavioral change. And you can see it will actually kind of give you a guidance, a lot like what Nasir was talking about, all these different ways that you can incorporate them into your communication plans. So what I did to respond to that question was I've actually downloaded this and I put it in your resource folders. So for those of you who are interested, it will be in there. So that's from my side, Aaron. Thank you.
Thank you so much, Lorraine. Okay, so I think now we have a few minutes left in the session. Do we have any final questions for the facilitators? We'll also have a survey as we're leaving the session, where you'll have an opportunity to write in any last questions, and we will be sure to address those questions at the start of tomorrow's session.
Yeah, Aaron, and if we could just briefly just talk about what we're going to cover tomorrow, again, just as a reminder.
Absolutely. Would you like me to project the
agenda?
No,
I can just do it from here real quick. Okay, so if there are any questions or anything that you reflect on later that you would like us to discuss or bring up, we will have a quick session in the morning where we can do that. So please share it with us, whether it's via email or in the chat or something.
Lauren.
Yes.
There's one question from Ibrahim, so it's on crisis comms, so in the chat box.
Could you please?
Yeah, I get this. What role can timely feedback play in crisis management? You know, most of our feedback has been through press releases and the media, unless it's done through stakeholder engagement. Yeah, this is obviously, it's the easiest to issue the press release and then use the media. It's like if C4D people said, oh, let's just do media communication, so we wouldn't have any C4D. But I think it depends also on your assessment of the crisis and how widely is it the potential impact of that. Just take one scenario. Let's say we're talking about religious sect. There's a religious sect leader in District B that refuses, has heard rumors about the COVAX vaccine, and so what should we do with that? Local stakeholder engagement with that religious leader probably is the most effective way. There's no need for media. But then if you have widespread rumors in a country, in media, in social media, circulating, and there's obviously no geographical limitations, it's in the digital social media, then the response has to be in those channels, because that's where the crisis is happening, and that's from where it will then spread into the offline world, and you will have big problem in your hands. So I think it depends on the assessment, what is the most appropriate response. But it's true that the media is often the easy way out to respond to a crisis, but sometimes it's also the appropriate way. It depends on your assessment and the type of crisis you're dealing with.
May I just add? This is Mariana speaking. I just wanted to add that absolutely agree with Tommy, though we do encourage specifically for NOPV and for other outbreak responses, we do encourage a close collaboration within UNICEF, external communication teams and C4D teams. For one of the reasons is the rumor management or misinformation management and crisis communication, but also to highly encouraging government counterparts to engage with the press service. Different countries have different setups, but basically to engage the teams that are dealing with media on everyday basis, because they also have the external communication teams and the media services of the ministry has the relationship with the media, and we advise for the off the record briefings ahead of time. We advise to set those relationship in motion to say, if you hear any rumors or any miscommunication, do let us know and we will be there to respond before they start publishing. So it is critical to have that crisis communication cell set up before the campaigns. And it's critical to have all the different communication parties at the ministry level, but also at UNICEF and WHO on board. So is well coordinated. Thank you.
Thanks, Mariana.
Yeah.
Go ahead,
Back to
Lorraine,
me?
with tomorrow. Yes.
Yeah, thank you. And thanks, Mariana. A good reminder that we work in partnership and support government. So just to touch on what we will be doing tomorrow, as I said, we'll have a review session in the morning, share anything you would like. We would like to talk briefly about data and how we use data to make informed decisions for our work, and then go to the behavioral component, addressing our audiences and community engagement. And then Kashan will talk to you all about misinformation and rumor tracking, and will actually also support us with a small animation. That's it from my side. If there are any other documents that you think you would really need besides what we have in our resource folders, please do reach out to us. Thank you. Over to you, Erin.
Thank you so much, Lorraine. So for our final activity of today, if you go to the chat box, there is a link to a survey. I'd like you to each take a few minutes, go to the chat box, click on the link, and there will be 4 questions asking for feedback from today's session. We'd like to hear from you. What questions do you still have about any of the topics that we've covered today? We'll be sure to answer those questions tomorrow. And for anyone who is in the room, let me project with the code that you could use. So you can go to slido.com, and I'll put that in the chat box as well for anyone on a mobile. So it's slido.com, and the event code is on the left, 7677.
Aaron, does that also contain the question about Friday start time?
Yes, it does. So you'll, the fourth question is geared towards our colleagues in Uganda, asking whether we can start this session 1 hour earlier if you're able to join at that time 1 hour earlier. So please let us know. And if this is not applicable for you, if you're in Sierra Leone and we'll be doing the Friday session another time, you can select that response. So we'll use your response to question 4 in order to confirm Friday's session, and we'll give feedback to the group tomorrow about the timing for Friday. So we have a few responses coming in, so please take another few minutes to complete this survey. And in the meantime, Lorraine, anything else from you?
No, I would just like to thank all colleagues for participating today. Very active, great discussion. We'll continue with this again tomorrow. We really appreciate it. And also, I'd like to really thank the Ministry of Health for being with us and our colleagues from WHO. Good partnership. Okay, thank you. Anything from Tommy or Mariana? And Aaron, thank you for your support too, and to all the facilitators.
Oh, nothing from my side. Look forward to engaging discussions tomorrow. Thank you.
Thank you.
Thank you all very much. Thank you, Lorraine and Aaron and all the facilitators. Looking forward for tomorrow.